So as you know, the brain have 4 main arteries giving supply. But anything can happen to them, especially diabetic, high blood pressure, cardiac patients. Accidents, strokes, aneurysms. And we need to face the problem. And we cannot do anything without you guys, without the whole team, without technologists, nurses, PA, RegTechs, yes. That's the, we work together for the benefit of the patient. This is Dr. Klosnik, my partner. We are very good friends. We worked together since 10 years ago. By the way, he had to come at 2 a.m. to do a stroke case. So this is becoming a nightmare or good for the hospital, but we're having, as Reina said, 4 cases per week, and we have to be available. And that's what the Methodist is offering, 24/7 coverage. So he has to cancel his case for today. It was an elective case, but of course, if you're coming 2 a.m., you need some rested. So we need to reaccommodate the patient for the scheduled treatment. And we have the aortic arch is here, and the aortic arch is giving 3 main branches: the brachiocephalic trunk, the left common carotid, and the left subclavian. So here, there are 4 arteries going to the brain. As Dr. Jackson mentioned, they are connected inside. It's the circle of Willis. So we have 2 vertebral arteries getting to the basilar, because this is important. The brainstem is supplied by the basilar artery, and the brainstem is controlling respiration, cardiac function, etc. So then inside the brain, we have the internal carotid here, and then the bifurcation is like a T-shape. We have the M1 segment. For the M1 segment, we have perforators going to the brain itself. Then the M1 segment is horizontal. Then the M2 segment is vertical. Then the M3 segment is horizontal again, and the M4 is vertical. So we have M because middle cerebral artery. This is supplying 1/3 of the brain. And we saw a lot of stroke at the previous lecture about the stroke of the M1 segment. So the internal carotid, the anterior cerebral, the middle cerebral, they are considered large vessel occlusion. If something has to be learned from this lecture from today, remember brain, time is brain, large vessel occlusion. That's what the patient come to the hospital to be reopen the artery, large vessel occlusion. This is what our role is to go there and do a mechanical thrombectomy. So this is again, this is the internal carotid injection here. This is the internal carotid in blue, and you have like a T-shape. This is ACA, anterior cerebral. This is MCA. The horizontal portion is called M1 segment. Then we have the M2 segment, vertical, M3 segment. So we have internal carotid is a large vessel occlusion. A1 segment is a large vessel occlusion. A1 segment is also considered A because anterior, M because middle. And this is exactly same patient but before. This is internal carotid here, internal carotid, but we don't see the M1 segment. So you know that this patient have a large vessel occlusion. TPA is not gonna work here. This is a big clot. We need to go to do something else. We need to go there and grab the clot out. So this is, M1 segment, occlusion of the M1 segment. This is the magnification. This filling defect, this little thing here, is the clot. It's a large clot. So, of course, M1 segment is basically one of the most important branches, but still, ACA is going to the anterior part of the brain, anterior cerebral, and the basilar is the one. This is the brainstem. So God made two vertebrals to supply the vascular because the vascular is very important. It's more important than any artery of the brain because this is supplying the brainstem. The patient can be in a coma, can be dead very quickly if we don't open the vascular artery. Also, we know the territories. The pink is the MCA. Look at that, it's a huge territory. So if we have an occlusion of the MCA, we can have a huge stroke. The patient is not gonna be the same after that. Green, we have the anterior cerebral, and in purple, we have the posterior cerebral. Okay, we are not including here, this is the brainstem. So we know exactly the territory. We know what the patient is gonna happen if we don't open that artery on time. So we need to start educating people, educating the patient, the family, the emergency doctor. Believe it or not, sometimes there are delays on transferring the patient from hospital to hospital because they don't know the implication of send the patient on time to fix the problem. Of course, there is also a connection inside the brain. So this is the vascular, this is the posterior cerebral, this is the internal carotid, that they are connected, circle of Willis. Sometimes, yesterday I did a case in Sugar Land that the patient have occlusion of the vertebral, occlusion of the other vertebral. So what happened to the vascular? Should be dead? No, because coincidentally, or lucky, the patient was lucky, the posterior cerebral artery was supplying the whole system. This is not constant. We don't have, everybody has not posterior communicating or anterior communicating. This patient have only one posterior communicating and prevent to be dead. Those is very important. Sometimes we don't have to open anything because there are collateral circulation. It's a dynamic study. So vascular lesions. We're gonna talk about the stroke, and we're gonna talk about aneurysm. But remember, sometimes we have this. The artery, this is the internal carotid, is supplying the brain, but for some reason, congenitally, there is a tangle of blood vessels connecting the arteries and the veins, making the veins dilated and weaker. They can bleed. It's more common in kids. This is called a cerebral arteriovenous malformation. This nidus, that is the problem, is inside the brain. So we call that cerebral venous malformation. But this one is another venous malformation, but it's not, this is the brain. The brain is covered by 3 layers. The strongest one is the dura. Dura in Spanish means strong. So you can have that connection, that tangle of vessels in the dura, and we call that dural arteriovenous malformation. So the brain is affected indirectly in the dural portion. But you can have AVMs in the liver, the skin, the eye, and they are similar, very similar, connecting arteries and veins. Remember, the arteries are getting smaller, smaller, smaller until the capillary bed. At the level of the capillary bed, you have exchanged oxygen and CO2, the nutrients and everything. So here, they don't respect that. They go arteries and veins connected through a nidus. This is abnormal with hemodynamic and clinical consequences. The patient can have seizures, headaches, hemorrhage, etc. And you can have this. This is an arterial malformation of the scalp. And this patient was is a doctor from Pakistan. This is just vein, dilated vein. That can happen in any place of the body. And it's like Caputo's medusa. And look at that, a lot of blood vessels connecting arteries to the vein. The treatment is very simple. We need to get where are connected and disconnected, surgically or endovascular. That's what we did. The connection was here. I put a needle there, injected some kind of glue. It's called onyx. That is ethylene vinyl alcohol. It's a glue. And then look at the glue inside. It's an arteriovenous malformation, not the brain, not the bone, not the dura. It's at the level of the skull. And this is the patient. And this, of course, once we close the shunt, has to be, all that extra skin has to be resected. The patient was very happy, and the wife also. So this is, you know, all part of the body needs blood. The, you know, all the, you know, the extremity, the liver, the kidney, but the blood going to the brain needs more blood, more flow. And this is basically 45 to 55 milliliter per 100 grams per minute. If this is normal, let's say 50, could be 45 to 55. Between 25 and 50, there is some changes at the level of the neurons, edema, lactate accumulation. If we go less than 8, is infarction. The brain is dead. The neuron is bred. So if we decrease the flow from 50 to less than 8, there is nothing to do. It's too late. But between less than 25 is hypoperfusion. So there is less blood, less oxygen. So brain is very sensitive to oxygen and then to hypoxemia. And then we have less than 25 is not good, but the worst is we don't want the brain to have less than 8 milliliters. So from 8 to 25, we have hope. We can fix the problem. If the patient is coming when there is less than 8, it's too late. How can be determined? This is similar. You know, 45, 50. 50 is the magic number, let's say 50. So less than 8 is an infarct. Less than 45 is hypoperfusion. Hypo means less than that. So less than 45 means that it's not exactly the same amount of flow. It's hypoperfused. But between 45 and 25 is oligemia. Between 8 and 25 is penumbra. Penumbra is the part of the brain that is hypoperfused but still alive. So we can go there, open the artery, and increase the flow and save that part of the brain. So what is our target? The penumbra. So when we do anything to prevent ischemia, to prevent an infarct, we need to work on the penumbra. If the patient already has an infarct, let's say the patient had the symptoms yesterday and is coming today, maybe there is no penumbra. Whatever happened, happened. It's too late. That's the reason time is brain. So let's do this. So this is the thrombus here. So then there is ischemia, then there is an infarction, and around the infarction there is penumbra. This thing here is hypoperfused, is ischemic. We cannot do anything to this. This is dead. So we need to go to there. We need to recover that penumbra. And, you know, sometimes, like in this one, no hospital, that's dangerous. Don't go there. So when we talk about what, you know, this is quick, Dr. Jackson mentioned about, there is two types of stroke. A stroke is a clinical symptom. The patient is changing the neurological status suddenly. He's talking, was given a lecture, and then suddenly stopped talking, you know, paralyzed the brain, the arm, etc. So if there is, because there is not enough flow, it's an ischemic stroke. But people think that a stroke is ischemic. No, a stroke could be ischemic and hemorrhagic. If the patient has a bleeding, it's a stroke, but it's a hemorrhagic stroke. And the blood can be in the parenchyma, the brain itself, could be in the subarachnoid space that we're going to talk about. Is an aneurysm is causing that, or subdural. So stroke is a clinical, definite diagnosis. Patient is doing okay, and suddenly. That's what we need to teach people. Go to the hospital. And this is very, very, very common. It's the first leading cause of death in US. And it's growing. It's a global epidemic. You know, diabetes, high blood pressure, diet, etc. So every time it's getting worse and worse. What to do? So if the patient is coming with penumbra, if the patient is coming with an infarction, what to do? Basically, nothing. Go to rehab. Try to save the patient's life. But if the patient is coming on time, less than 6 hours ideally, we're going to talk about 4.5 for ITPA. So if the patient is going to a hospital that there is not interventional neuroradiologist, no no vascular neurologist. It's medical management. Okay? We don't have anything to offer. That happened, my mother was okay 2 hours ago, and then what to do? It's what to do. So we don't have anybody. Some hospitals, they are not allowed to give any TPA we're going to talk about. So they say, let's wait, and then send the patient for medical treatment. Just try to save the patient's life. And believe it or not, that happened in the US. Very common in the third developed country, but it's happening still here. In some small hospitals that they don't have any comprehensive or primary stroke center, that they cannot give TPA. It's very uncommon, but it's possible. Very common in South America. So you say, you have Penumbra. We know that they can be salvaged, that brain, but we don't have TPA. We are not certified to do that. Or there are some hospitals that they are authorized to give TPA. Do you think that the TPA is going to work destroying the clot? If the larger the clot, the worse for TPA to work. So sometimes TPA is not working, and we're going to talk about it. So it's approved for 4.5 hours. That's another interesting point. So the patient is coming. When it happens, it's 8 a.m. It's 10 a.m., so give TPA. It's more than 4.5 hours, don't give TPA. It's going to be worse. Dr. Jackson mentioned the contraindication, and she talked about that. And then what happened if the patient is less than 6 hours, sometimes 8 hours? We can go there, put a catheter in the groin, go to the brain, to the MCA, M1 segment most of the time, Vascular, grab the clot out. This can be done from 0 seconds, that is difficult, to 6 to 8 hours. What is the ideal? To say, if the patient have a penumbra, bless you. If the patient have a penumbra. If it's 9 hours and there is a penumbra, go ahead. We say 6 hours, but it's not that the brain, you're going to say it's 5 hours, 59, 6 hours, let's stop. No, depend on the clinical condition. Sometimes we need perfusion and diffusion and see what is the penumbra clinically. But basically, there is a penumbra, go and save that 2 or 3 neurons, whatever can happen. So this is medical treatment, TPA, and mechanical thrombectomy, or mechanical thrombolysis. It's the same. And look at that, timing is critical. This is based on the IMS trial 1 and 2. For the TPA, this is the TPA, the longer the time, so basically the TPA after 300 minutes here is better not to do TPA because it's the same or even worse. Every 30 minutes, 10% of the brain is lost. Every 30 minutes. And, it makes sense, but not in medicine everything that makes sense is true, but this is true. Recanalization. If the artery is occluded and we open the artery, the patient is better. But if we open the artery when the brain is dead, the patient is not better or could be worse. Because we're opening an artery that is going to cause some problems to a brain death. So definitely, scientifically has been demonstrated that recanalization is strongly associated with improved function, outcomes, and reduced mortality. And then there is a stroke system. We are having meetings every week. There is a lot of conference. So that we need to provide public education, and this is one of your roles after today. Teach family, teach medical students, nurses, PAs, everybody, even the ambulance, the EMS. We need strong collaboration with the neurologists, interventional neuroradiologists, neurosurgeons, nurses, technologists. They have to understand this. If they don't understand, they are not putting the patient on the table faster. So this has been studied, interaction. And this is part of the interaction, educate. So this is all the EMS has to be involved. And they have to know where to take the patient. If they take a patient to Willowbrook, Sugarland, they don't have an interventional neuroradiologist 24/7. So there are different type of center. This is the primary stroke center. So there is a focused, dedicated stroke program. So the staffing is qualified, they understand what's going on. So they know what to do with the patient after the patient is discharged. And they can use the data. This is called primary stroke center. And the comprehensive stroke center that the Methodist is, and I think this was the first comprehensive stroke center in US, have all the components of primary stroke center that can give TPA. A primary stroke center can give TPA. But then we have everything here. We have 24/7 availability of personnel, imaging, endovascular, technologies, etc. We have the experience. So this is completely different. And this is what happened. The comprehensive stroke center, we can do medical management, we can do TPA management, and we can do mechanical thrombolysis. And the EMS, if the patient is taken to a regular hospital that is not even primary stroke center, has to go through that. The hopes are less because it's wasting time. So ideally, they should understand if the patient have an LVO means LVO, large vessel occlusion, is coming directly to the comprehensive stroke center. But sometimes they take the patient to the primary stroke center, which is okay. They know what they're doing. They can give TPA and then initiate the stroke call. They call and then they communicate with everybody, and we come to the hospital to do this, the mechanical thrombolysis. So this is, already why time is important to recover the ischemic penumbra. This is yellow, is dead. This is the normal brain. But between the brain and if we don't do anything, this penumbra is going to be yellow. So we need to work, whatever we do is to recover the penumbra. As said, 10% of the brain every 30 minutes, or almost 2 million neurons per minute. So for every hour that we delay the treatment, the brain is going to be older 3.6 years. This is important. And this is even better. This is in Germany. This is an ambulance, a stroke ambulance. There is one here in Houston, and Cleveland Clinic. I think Houston was the first in US or the second. And then this is Dr. Grota. They have a CT, because what Dr. Jackson said is completely true. The patient we need to rule out bleeding, because if the patient, we don't know clinically, we don't know for sure if the patient have an ischemic stroke or a hemorrhagic stroke. Sometimes they overlap. So we don't want to give any TPA in something that is bleeding. So they go to the patients, pick the patient up, and immediately they do in the ambulance a CT scan, so they know that there is no hemorrhage. That's the first thing to do. There is no hemorrhage, give TPA the ambulance. So before the patient go to the hospital, already has been treated. So this is like that. So they are treating before, this is important. It's a mobile stroke treatment. And dramatically cut time, just coming to the hospital in 30 minutes and the patient is 10% more brain. And this is what they have. They have a CT scan, it's protected radiation, so they know. It's unbelievable. So the patient is here, so we need to give TPA, is 4.5 hours. Destroy the clot. It's intravenous, easy to do. What we need, a CT scan of the head before, no bleeding. There is bleeding, no TPA. It's a catastrophe. Okay, but look at that. Only 8% are eligible for TPA because it's 4.5 here. They changed for 3 to 4.5. So it's not a lot of strokes. And this is what happened. This is what happened. This is the clot, a lot of platelets. This is the plasminogen, that is a molecule that is not active. So the TPA is coming, join the plasminogen, make a plasminogen in plasmin, and the plasmin is what is going to destroy the clot. So TPA is taking the plasminogen to plasmin, and the plasmin is destroyed the clot. That's the way it works. So, but not if the patient is taking anticoagulant, Coumadin, Prodexa, no TPA, it's a contraindication. If the patient have a stroke recently, no TPA. So it's a lot of contraindication. So what to do? Before 2 years ago, before last year, we tried to do mechanical thrombolysis, but now it's proving, we're going to talk about. So if the patient is failing TPA because the clot is too big, so there was nothing to be done. And also, what are the reperfusion limitations? Is the distal ICA only 4.4% can be open with TPA because it's a big blood vessel. N2 is the 30%. M1, that is the most common, 30%. So 70% of the M1 occlusion, that is the most common, 70% TPA doesn't work. So if the clot size is less than 8 millimeters, it's good. But sometimes it's more. So why to waste time giving TPA, or if we're giving TPA, at least it's working while the patient is transferring. Okay, look at that. In this study, only 2.4% receive TPA. It's not a lot because education, the patient is not going to the hospital. Let me go there. So 35 to 40%, let's introduce this term, large vessel occlusion, LVO. And what is the large vessel occlusion? We say it internal carotid, M1 segment, or MCA, and vertebral and vascular. If we don't treat this with mechanical thrombolysis, look at that. The mortality, if the patient have an ICA, internal carotid artery, big vessel, the mortality is 50%, 53%. If we don't do anything for an NCA, the patient is dead in 30%. And look at that, the vascular artery, patient is dead in 90%. Last Friday, I have a 37-year-old patient in a coma with a vascular artery occlusion, 90% mortality. And we need to say, we don't do anything, he's gonna die 90%. I went there, grabbed the clot, I think it was 10 minutes. Next day, the patient was moving everything. And is still in the hospital, but it's ready to go home. So this is unbelievable. So what is the goal of the treatment? To open, revascularization. This is the right internal carotid, this is the ACA, should be a T here. There is not blood vessel here. Aster, interventional. M1 segment that is short for some reason, M2 segment, and then the rest is open. That's the goal. So we coming, the patient is awake. We're coming, we puncture the right femoral artery, we put a catheter, we go directly, we know what is the sequence. The patient is coming to the ER or is transferred from another institute facility with a CT scan, no bleeding. We do a CT angio because we need to know if the patient has a large vessel occlusion. If there is an M3 occlusion, we don't have to do mechanical thrombolysis. TPA works most of the time. So we know that the patient already has a left MCA occlusion, so we go directly to the left MCA. We don't give any heparin, we go directly, very quickly. And this is a case a long time ago with the urokinase was available. Look at this one, internal carotid, T here. We see this branch, okay, but we don't see this branch. We go with the microcatheter and we start injecting. This is like a TPA. We don't have it. And then the TPA directly in front of the clot destroy the clot, and this is after. It's open. We don't have urokinase. Can we do that with TPA? Sometimes, but we are so successful using the clot retriever that we don't have to go and start injecting in front of the clot. So let's talk about approved retrieval device very quickly. We have something that is aspirating the clot, and we can use those catheters and aspirate it. Sometimes the clot occlude the tip of the catheter, so we need to use a separator. But we have this one, Solitaire, Retrieval, Penumbra, 3D, mid-frame, all this clot retriever. Okay. So this is one of them. This is the clot, this is the internal carotid. We open this stent that was developed, was an accident, the way that they demonstrate that this was good to grab the clot. So the clot is getting inside that mesh. And then basically we go to the brain, we do. We put a catheter here in the internal carotid. This catheter has a balloon there, but we don't inflate the balloon. We go using road mapping. So we go with a very soft wire. We go through the clot. And we go through the clot with the wire. Then we hold the wire and push the microcatheter. We go with the microcatheter through the clot. Take the wire out. Go with the clot retriever. Hold the wire and unsheath. Hold the wire here and unsheath. So this is opening. Then when it's opening, we wait 5 minutes. Immediately we have flow, because this is opening a lumen. So still it's getting oxygen to the brain. Then we wait 5 minutes, 3 minutes, just to get this well expanded, but it's already there. Then there are two techniques. I don't use this one, but this is one, inflating a balloon to prevent the clot to go distal, and then we brought the clot inside. Very effective, very easy to do. This is one of, you're ready after this, This is the right vertebral, this is the basilar. As I said, the mortality is what? Basilar occlusion? 90%. So this is after, it's open. Okay, here. What artery is this one? Internal carotid. And then should be a T. This is the ACA, and what is this? MCA, M1 segment. There is a little filling defect. I don't know if you see it there. There is a clot there. This is after I showed you this case. And the patient is going to have a stroke after the procedure. Depends. If there was no penumbra, it's going to be a large stroke because it was too late to come here. Sometimes we don't know when was the start of the ictus. Sometimes the patient wake up with the stroke and was more than 6 hours, and we don't know. But we try to open. Sometimes this patient develops small infarct. Look at that. This is internal carotid. Mortality of this one, if we don't do anything, is 50%. Mortality for M1 is 30%. So this is complete occluded. It's even worse. The whole internal, no ACA, no MCA is open now. And this is the clot. Small one here is a filling defect, should be black. And I didn't see this one, there was another one here. This is the ACA. It's open, both are open, so I got 2 for the price of 1. 2 open with the same device. And those are the clots. We always take pictures and we measure. We're sending to pathology also. So that's different type of clot, different materials, white clots that we're getting. So we're coming from the pre, making beautiful. So if one is good, solitary is good, so another company has what is called the Retrieval. It's very similar, copycat, different company. And all the company now that this is developing. So one of the things that we say is aspiration, the company is called Penumbra, that we go there with the catheter and aspirate the clot. And Solitaire grab the clot without aspiration. I like the combination of both, Penumbra and Solitaire, so they call Solumbra. So what I do, I don't inflate the balloon proximal. I go with the big catheter, and then when I'm taking the Solitaire or the Retrieval inside, I'm aspirating. So I think I like it, and I have good results. Of course. Okay. So then they say, makes sense, go and open the artery, should work, but it's not as easy as that. Say, let's demonstrate that the patient is doing better. As I said, in medicine, what makes sense doesn't mean that it's true. So that makes sense, but we need to demonstrate it. So, and we have this study. This was in a couple of years, it was in 2013, IMA3. They say, makes sense. The mistake that all the patients with a stroke, with an ischemic stroke, we were comparing TPA versus TPA plus mechanical thrombectomy. We didn't have Solumbra, we didn't have Solitaire. And then this was published also, IMA3, and demonstrated that was because it was stopped early, because we didn't demonstrate that what we were doing was better for the patient. The problem is that we were putting all type of little clots in the distal branches that we don't go there. Another trial, still endovascular treatment, no. Endovascular treatment was not superior. IMA3 and synthesis. MR rescue, same. So in 2013, say, you guys, you're opening, the patient is not better. And then, let me see, this is going to be off. This is a good one. So we were sad because everything we did was not good. So IMA3 rescue and synthesis didn't demonstrate that what we were doing was good. So and then they say, hey, let's review why it doesn't make any sense. So in Netherlands, they say TPA is not good. Let me see if you remember. What is the size of the clot for the TPA to work better? Exactly. So they say, see, the TPA is not good in larger than 8 millimeters. Let's see what happened to those patients. So in Netherlands, they say the Mr. Clean. That is, this Mr. Clean is because in multi-center randomized, you can read this. So they say that the government said, all the patients, if you want to get money for mechanical, we were doing this. I did my first mechanical thrombolysis 18 years ago. We didn't have the material we have now, but we need to demonstrate scientifically that this is working. And then sometimes we do it, sometimes we didn't do it. So in Netherlands, the government said, everybody's going to have mechanical thrombolysis if the clot is bigger, and if you don't do that, we don't pay that. And believe you, the doctors start doing it. So all the patients, it's not like whenever I want to do it, or the neurologist want it, or my cousin, no. If you don't do it, we don't pay. So Mr. Clean is not for US. And the Mr. Clean save us. Start with. Yeah! And it was published in the New England Journal of Medicine, one of the most prestigious journals for the Mr. Clean investigators. And then this is the design. The patient has to be in bad neurological, Dr. Jackson mentioned this, anterior circulation, elbow, large vessel occlusion. Don't do it. The patient is having symptoms that you don't know where the clot is. But the clot is, I have 5 minutes. Thank you very much. So if the clot is, so you need to confirm. You need to see that the clot is, so confirmation, this was different. 100% of interventional stroke center should be participating. It's not like a sometimes whatever I want. And definitely with interventional versus non-interventional, this is the ranking scale. You know, the 1, 2 are basically very functional, 1, 2, and 3. Look at this one for control versus interventional, more people. So what's the first? What's in 2015, Mr. Kling? So they say that is 32.6% were functional versus basically 20% if we do mechanical thrombolysis. So Mr. Kling, after IMF3, synthesis, MR rescue that show what you're doing, don't do it in everybody. Find specific patient. And Mr. Kling was the first one. Simultaneously, let me show you because simultaneously, so everybody start talking about that. Then Rivascat, Extend IA, all this 1, 2, 3, 4, 5, plus Mr. Kling demonstrated in US that mechanical thrombectomy in a large vessel occlusion, not in small vessel occlusion, was better. And this was a boom in the Medscape, New York Times, and this is a procedure that is accepted by FDA, and we're becoming better and better. So the future is engineering. So Solitaire was the first one. So it's easy to do. This is a relatively easy procedures. And thanks Solitaire to be here and the rest. So I think that I prefer to give time for questions because I have 5 minutes or 5 minute plus questions. What is the? 10 minutes. 10 minutes? Okay.
How do you determine the presence of a penumbra? Is it based on time of last known well, perfusion pressures, imaging? How do you determine that?
Clinical, the most important is the clinical presentation. It's time of known well. The problem is when it's a wake-up stroke, so that we don't know. We know that most of the wake-up strokes happen after 3 a.m., has been demonstrated, but could be at 10 a.m., and then when the patient is coming at 7 a.m., has been more than 6 hours. So now it's a lot of MRI sequence. If we have perfusion sequences versus diffusion, remember Dr. Jackson said diffusion detect the stroke, the infarct, diffusion. If we have an MRI with a diffusion and it's bright, we know this patient has an infarct already. That part of the is dead. If we know what is hypoperfused, but is not diffusion positive, so the difference is hypoperfused or penumbra. But still, we need to waste time doing it, but it's worth it. Now, so what is the ideal situation? If we know if the stroke, the patient is doing perfect and then suddenly have an hemiparesis, this is what the patient had the stroke. So last, well known. The problem is the wake-up stroke that we have to use eventually. Perfusion, less diffusion, is exactly the same what is hypoperfused. Exactly the same volume that is infarcted. Don't touch this patient. You're not going to get the patient better. But still, we're in the process to develop, to do it very quickly. But my personal opinion is that we should do it in those cases that we don't know, doing perfusion and diffusion, and see what is the area of penumbra. If the area of penumbra is more than 100 cc's, it's worth it to go.